routinely evaluated with ECG, echo and treadmill. Treadmill turned out to be inconclusive. Again in January 2026, he presented with chest pain to a cardiologist. This time ECG, echo and TMT were done. TMT turned out to be negative and he was referred for a gastroenterologist. He was evaluated and diagnosed, treated as gastritis. But in view of persisting chest pain, ECG was done and TROPI was done. Initial ECG was showing inferior MI, but it was missed, and TROPI turned out to be negative even after 5 hours of chest pain. And later, patient progressed to heart failure, and this time ECG was showing evolved inferior MI, and he was referred for further management. So, what are the shortcomings in this case, and how the things like AI in ECG and AI in echo are going to help in further management? So what's the burden actually? When we are quantifying missed MIs in emergency department, this is a study conducted in US, and review of literature showed 12 million diagnostic errors happen annually, and 1/3 result in serious harm, and 10,000 myocardial infarctions are missed annually. So in this paired method, we look at a case, we'll go back to the history, look how he presented and any previous visits to ER department, and also we look at the prognosis and outcome of management. So what did this study show? It showed that of all the heart attack admissions, 1.3% were missed during a recent prior visit. And also of all the patients sent home with chest pain or dyspnea, 0.2% returned with heart attack within 30 days. And when the subgroups were analyzed, we can see that female sex was more predominant, like in non-missed groups it was 36.3 and in missed group it is 43.4% were females. And also blacks in non-missed group were 11.5 and in missed group it is 14.5. And also lower social and economic status and lower education levels are more prevalent in the missed groups. And coming to the clinical paradox, we can see that the diabetes, hypertension and smoking history are more prevalent in the missed group compared to the non-missed group, but still the diagnosis is missed. So what's AI? AI, like machine learning, we give a feature to the machine and it analyzes it and it classifies. Whereas it coming to the deep learning, the human factor is out. And come to the federated learning, it takes the population into study in different areas and then the data is combined and it is superlated to the study population, which can be from any part of the country. So how AI is helpful? Like in a general setup, when a physician is treating the patient, it relies on human interpretation of the findings and symptoms, and that's how we arrive at a diagnosis. Whereas AI can have two roles here. One in improving the diagnostic accuracy and helping in the early management. The number two is it conducts secondary analysis to identify possible diseases. So in the first, we look at the acute setting. That means how AI in ECG is going to help in increasing the accuracy and early diagnosis and management. This is a study, multi-center study conducted in United States from 3 primary PCI-enabled centers. Out of all the STEMI activations, we can see that the true STEMIs were only 58% and STEMI mimics were 42%. That too in the true STEMI, only 40% had standard definition of ST segment elevation on the ECG. And out of the 42% mimics, 52% proceeded to cath lab. That means that's a huge waste of energy and resources. And when AI algorithm is applied here in these patients retrospectively, it showed the sensitivity of 92% compared to the standard of care of 71%. And false positive activation rate was low when AI was assisted in interpreting these ECGs, and it is 7.9% compared to the 41.8%. And also door to balloon time, which is very important in managing the STEMI cases. The mean door to balloon time was 59 minutes in patients who were missed by standard of care. So when AI assisted ECG and standard of care were compared across the different ages, across different sex, and rhythm disturbance like AF, LVBB and RVBB, we can clearly see that AI sensitivity and specificity are higher than the standard of care sensitivity and specificity. We can look at its graph. The area under curve is quite high across all the three sites. And also the sensitivity and specificity of standard of care is only 71% sensitivity and specificity of 29%. Whereas when AI is used in assisting managing these cases, the sensitivity is 92%, specificity is 81%, and false positive rates are only 7.9%. So when we look at the mimics, AI is quite helpful in ruling out the diagnosis. The majority of the non-biomarker elevation false mimics were early repolarization variants, non-specific STT changes, left ventricular hypertrophy, LVPB, and non-specific intraventricular conduction delays. In all these cases, AI is quite helpful in ruling out the disease, and true negatives are quite high compared to the false positives. Whereas in biomarker elevation, the sensitivity and specificity are not that much. And coming to the main point, like in all these two STEMIs, when we look at STEMI equivalents and conventional STEMI equivalents, that means where hyperacute T waves are seen, in all these cases, they were 238. Those were the 42%, which initially never showed ST segment elevation, but angiographically they had visual occlusion. In all these cases, the door-to-balloon time was STEMI equivalent was 88 minutes, whereas conventional STEMI is 69 minutes. And also, the target door-to-balloon time of less than 90 per minute was only achieved in 175 cases in STEMI mimics, whereas in conventional STEMI it is 307. So the takeaway is like standard of care detected only 58% of the STEMI mimics, whereas the AI detection rate was 84%. And patients with STEMI equivalents had significantly longer door-to-balloon times because they were not immediately recognized. Coming to now, we have discussed the acute scenario. Coming to the stable angina patients, deep learning analysis of 12-lead ECG to detect angiographically significant CAD and validation of ECGO model via multi-center rope study. In this, the data was collected initially and it was internally cross-validated, and then external validation was done. And it was compared to the angiographic outcomes. So what's the basic funda of this ECGO? ECGO, it identifies the disease in orthogonal lead space. That means we look at only the STT changes, but ECGO studies the orthogonal lead interactions, phase relations, and dipolar activity, and analyzes interdependencies among leads, which was humanly impossible to identify. So when the internal validation was done, and out of all the data, the model which has highest area under curve was taken, and it is subjected to the external population. We can see across the different age groups of less than 65 or more than 65, across different sex or risk factors, the area under curve is quite good with both internal validation and external validation. Even when there are multiple risk factors or zero risk factors, the area under curve is maintained, even though it is quite high in patients with high number of risk factors. And one more point to notice here is when internal validation was done, the prevalence of disease is 64.5%, whereas the external validation population had low prevalence, that is 36%. Still, the AI-assisted ECG is helpful in diagnosing with a specificity of 90%, and it has a negative predictive value of 88.1%. That means we are effectively able to rule out the disease, even in stable angina. We can see in this chart, like in cross-validation, ECGO truly identified the disease in 8,678 patients, and it showed true negatives of 5,087. The results were same even in the external validation population. So when we took a treat none and treat all strategy, the area under curve when ECGO was implemented, it was quite high compared to all treat all or treat none strategy, and the net benefit is high. Not only in STEMI like coronary artery disease, this AI-assisted ECG is also helpful in identifying atrial fibrillation, flutters, electrolyte imbalance, digoxin toxicity, and even the pericarditis, the musculator like the pulmonary embolism. Compared to the human experts, the AI algorithm has higher sensitivity and specificity. And one more thing I would like to highlight here is like the paroxysmal AF, when AI is used, the new diagnosis of AF significantly increased from 3.6 to 10.6%, and also the prescription rate of NOACs is high when AI-assisted ECG is used in identifying. The other thing is atrial low EF and HCM. And one more important thing is this AI and ECG in acute STEMIs, it's helpful in reducing the door to balloon time. Coming to the cardiac biomarkers, we all know we have progressed from AST, ALT, and ALDH as cardiac biomarkers to now high sensitivity troponin I is used. So we know the kinetics, it starts elevation from the third hour and peaks at 24 and does down at 10 to 14 days. So what is this high sensitivity troponin? How is it different from the routine troponin? When it is measurably more than 50% of the healthy population, then it's high sensitivity troponin, and coefficient of variation should be less than 10% of 99 percentile. And how is it helpful? It's helpful because as per the new guidelines, TROPI is used as rule-out diagnosis for ACS. Sometimes we get false positive and false negative, as I discussed in the case previously. That's due to the HEMA or heterophile antibodies, which block the site of binding the troponin I. And also in special populations like CKD, where there will be elevated tropa at the baseline, in such cases we look at the serial elevations. And false positives are high in infections like sepsis, critical illness, renal failure, and myocarditis, pericarditis, heart failure, and traumatic contusion. So are the only patient factors affect these troponin values? This is a ABACE multicenter study which showed regulatory inconsistencies in different troponin assays. This was all in patients with, this study was conducted and study population is suspected MIs. All the types of assays were used where Roche's Alexis is troponin T and rest all are troponin I. When the same sample was analyzed with different analyzers and was compared, we can see the discrepancies were high when trop T and trop I are compared with each other. And also the discrepancies persisted even when trop I is measured in different machines. So this mismatch was higher in elderly population and also the patients with renal dysfunction. So how are we going to answer this? By switching to mathematically derived close to bioequivalent upper limit of normal, the proportion of these mismatches came down by 15 to 20%, but it's not still zero. But the mismatches still persisted when trop T and I are compared. This is because of the differential release patterns of the trop T and trop I. Coming to AI in imaging, these are the different studies where AI is used for image acquisition, image analysis, like global longitudinal strain and assessing mitral regurgitation, aortic stenosis, looking at the aortic annulus and different measurements used for TAVI planning, and also LVH and assessing LV filling pressures and regional wall motion anomalies and stress echocardiography. So coming to our point of discussion is coronary artery disease. So I look at it. So this was a study where automated echocardiographic detection of CAD is studied using AI-assisted stress echo analysis, comparing both like reader analysis and AI-assisted. The use of AI in this scenario is particularly important because when we are looking at the stress echo, the operator should be clearly trained in stress echo and the volume should be high because there are high inter-observer and intra-observer variability. And also the AI takes into the account other features like kinematics like endocardial velocity, tardokinesis, and geometry like shape deformation and wall motion anomaly. So in this study, the AI is used to internally validated using a UK population, and the same model is used to assess the external population which was conducted in US. And initially, whoever are reading the echocardiogram were given an individual report, and then AI-assisted reports are given both in 50% of the cases at one point of time and 50% of the cases and at a different level. The results were the sensitivity jumped from 85 to 95% when AI-assisted algorithms were used, and specificity remained the same. So the conclusion is AI assistance significantly improves the disease detection without compromising the specificity. And also the confident reads increased by 10% and the non-confident reads among these clinicians decreased by 29% when AI algorithms are used. This is a multi-center study where AI Echo Go Pro assisted analysis for referring patients for CAD for angiogram was used, but in this study, it failed to show non-inferiority of AI augmented stress echo in referring cases for invasive angio. This is because of the low angiographic referral rates in the study population, which is only 8% compared to the 15% in the prior observational study. But subgroup analysis suggested potential benefit of AI augmentation in low volume centers and improving clinical decision making for less experienced clinicians. So final takeaway, like resting ECG is only useful in acute coronary syndrome and it is poor predictor for stable angina, but whereas when AI assistance is used, it can be used as a tool. Whereas TMT, it has low sensitivity and specificity of only 60 to 70%. It is best in intermediate pretest probability and interpretable ECGs, and it can't be done like baseline rhythm analysis like RBBB. And troponin, it is detects only myocardial injury, not anatomical CAD. Whereas CT-CAG has high sensitivity of more than 95% and specificity of 80 to 90%, and it is an excellent strategy to rule out obstructive CAD. Thank you.